All right. Hi, everybody. I'm Lucian Sekeli, a PharmD candidate at the Wegman School of Pharmacy. And today, my novel therapeutic that I wanted to be talking about is Andembry, or garadacimab. It's a agent that's used in the hospital setting for cases of hereditary angioedema. Let's get started. So I have 4 learning objectives, as you can see here. The first one being to define hereditary angioedema and list the usual causes of it. We also want to describe how Andembry works to prevent attacks of HAE, identify the safety and efficacy components associated with Andembry, and lastly, to compare Andembry to the current standards of care for HAE. So let's talk about hereditary angioedema. It's commonly defined as swelling of the tissues under the skin, like in the face, eyelids, ears, or tongue, or areas that can cause a notable puffiness, which can sometimes lead to serious problems like trouble breathing. And it's the trouble breathing that we're really concerned about with angioedema and something we need to counsel our patients on. It can be caused by many things, including medications like ACE inhibitors, NSAIDs, and some antibiotics, but it can also be allergy mediated, in which patients may have a hypersensitivity to certain foods or environmental factors like nuts, shellfish, insects, insect bites, and things like that. But there's also a rare genetic link with some forms of angioedema where there's a hereditary genetic factor that can run in some families and make people susceptible to it. The effects that people usually have when they have one of these attacks are things like belly pain, swelling of the throat, and things like that, which can last 2 to 5 days. But if it's a more serious attack, like trouble breathing, then it could be fatal. So we want to be aware of that. And the general approach for any like anaphylactoid reaction would just be antihistamines and steroids and other things like that if they don't have one of these agents they can use. So let's talk about Andembry itself. Its generic name is garadacimab, and it's indicated for the treatment of hereditary angioedema in the hospital setting. It does have an interesting mechanism of action. As a monoclonal antibody, it's a fully human one, and it acts on the as a factor 12A inhibitor, which is administered via the subcutaneous injection. It's also an immunoglobulin G4 antibody, which is active against the activated form of factor 12A. This factor 12A that we're talking about here is a key protein that's involved in the blood coagulation cascade in human blood plasma. And as such, Andembry can decrease the activation of the plasma Kelly-Renin-kinin system, which thus reduces the overproduction of bradykinin, which is the potent endogenous vasodilator that's responsible for triggering attacks of angioedema. Let's move on to the safety and efficacy to consider when using Andembry. So as far as the safety is concerned, you want to monitor for side effects. And the most common side effects with Andembry use are things like injection site reactions and bruising and things of that nature. Also, patients can have abdominal pain and cold-like symptoms like nasopharyngitis. And for the efficacy, they mostly just want to make sure that the patient's having a reduction in symptoms and it's actually working for them. And how they measure this in the clinical medical literature is by the amount of HAE attacks in 1 month. So if they're having a reduction in that, then it's being efficacious in that patient. And also, we want to see less functional impairment in those patients as well. Just straightforward things. We want to make sure it's actually working. So next, I wanted to talk more about the current standards of care versus Andembry for these HAE attacks in the hospital setting. So right now, there's actually a lot of medications that they can use for Andembry, and like we were kind of discussing earlier, it can be a very patient-specific type of disease state, being that it has the hereditary component. So that's most likely why there's so many different available treatments for it as well. So looking at the WAO guidelines, you can use plasma-derived or recombinant C1 INH replenishment strategy, and or they can use another drug called a acalagutide, which is a kallikreinin inhibitor. So it acts on that same pathway we were talking about with Andembry. Or they can use a incambant therapeutic, which is a bradykinin B2 receptor antagonist, if they're looking for on-demand treatment in like acute situations. There's another monoclonal antibody called lanadelumab, which is an anti-active plasma kallikreinin monoclonal antibody. So that can also work on that pathway to help alleviate the HEA attacks. There's another drug called betralostat, which is another plasma kallikreinin inhibitor, and they can also use attenuated androgens, and another drug called tranexamic acid as well. So as far as Andembry is concerned, and I think this is one of the major benefits of it, it's just one drug that works pretty effectively on that pathway to help inhibit HAE attacks. And it's used for the prophylaxis of HAE, so just making sure they don't get it to begin with. And it has a loading dose of 400 milligram sub-Q injection the first month they're on it, and then that's followed by 200 milligram sub-Q once monthly injections as well. And there's some notes here as well about what to do if there's a missed dose. You just want to retake it as soon as possible. It's just once a month, so it's a little more, it can be more lenient in that regard. And there's no dose adjustments either, unless for pediatric patients, clinicians may want to consider dose reduction. But as far as the current standards of care, it's much more straightforward and can be a lot easier for patients to adhere to as well. So the next thing I wanted to discuss today is my first primary reference. And I used, actually on PubMed, I found a Vanguard trial that was looking at HAE. So for the background and purpose of this trial, like we were discussing earlier, it's focusing on HAE, the rare and life-threatening genetic disease in some patients. And it was aimed at assessing the safety and efficacy of garadacimab or Andembry. And that was still the once monthly sub-Q injection. So they're trying to see how well it works and if it's safe for patients. So the methodology, being the Vanguard trial, which is a landmark trial in the medical literature, which we may be somewhat familiar to from CEML, it was a multi-center, randomized, double-blind, placebo-controlled phase 3 clinical trial that recruited patients aged 12 years and older with type 1 or type 2 hereditary angioedema across 7 countries, including Canada, Germany, Hungary, Israel, Japan, the Netherlands, and the US. And it was randomly assigned in a 3-to-2 ratio, where 3 to every 2 would receive the intervention garadacimab, and then the smaller group would receive placebo, which was a matched volume basically of placebo each month. And it was over the course of 6 months, and it was the same dosing we discussed earlier. Their N, or the sample size they used, they had 76 patients for it, which doesn't seem like a lot, but for a very rare disease state like this, I would say that's actually a decent number for the specificity of the disease state and patient population that they're looking into for this. So as far as the results were, I found that, they said in there that the mean number of investigator-confirmed HAE attacks per month was significantly lower in the garadacimab group on a 95% confidence interval than it was in the placebo group. And they also mentioned that the treatment emergent of adverse events were upper respiratory tract infections, nasopharyngitis, and headaches. So things of that nature. And I just wanted to mention here too that being that it was a multi-centered, like massive 7-country-wide trial, and it was randomized and double-blinded, placebo-controlled, it really adds to the internal and external validity of the trial. Is what I was thinking, and so it really helps with the validity of the results, as well as they had some positive findings for that might guide clinicians to want to use it, I would say, as well. So my second primary resource that I looked at was actually an extension study that I also found on PubMed. So it was an extension of the phase 3 clinical Vanguard trial, but this was a more long-term efficacy study on the drug itself, which evaluated those long-term safety and efficacy components. And in this trial, the cool thing was they were able to use a lot of the same patients that were in previous Vanguard trials because it was the extension study. And this one's looking at primarily the maintenance dosing because it was the long-term trial. So the 200 sub-Q monthly. And so the primary endpoint that they were assessing were what they called TEAEs. Similar to the previous trial, these were the treatment emergent adverse events. But specifically this time, they were looking for those in C1 deficient patients. And like we said earlier, C1 is that pro-inflammatory plasma protein that has a key role in that pathway that triggers angioedema. So they're specifically looking at how the drug works in those specific few patients that are actually much higher risk for angioedema. So it was really interesting in that regard. As far as the results were concerned, most of the patients did experience at least one TEAE, which was 500-something events. And most of them, though, were injection site reactions, and there were no deaths. So the TEAEs really that they found here were either mild or moderate. So even though they found some, I would say it doesn't really discredit the safety of the drug because they were mostly mild ones as well. So, and just looking at the discussion, it still had a lot of positive findings for the use of Andembry clinically. So my next slide is on comparing the use of Andembry to the current standards of care in the medical literature. This is kind of just a miscellaneous slide because I found several other sources as well that also supported the use of Andembry, so I wanted to highlight those as well. So you'll see on this slide some things that I underlined that I thought were really important. One study found a significantly lower rate of HAE attacks in the garadacimab group with a percent difference of 86%. And another study showed that the drug is the most advanced and has shown potential as another novel long-term prophylactic treatment for patients with HAE in the clinical trials. Another one shows significant reduction in the rates of the attacks as well, and other things like that that I thought really showed promising data, but were outside of those two primary sources as well. So this is here also. So that really brings us here to the place in treatment. So this is an important thing to talk about as far as the perspective from practitioners, clinicians, and pharmacists. Basically, I think we'll start seeing more of the use of Andembry in clinical practice because it works. The data is really promising in showing that it reduces those rates of attacks and it's effective as prophylactic treatment. even in those high-risk groups. That said, however, it is a monoclonal antibody, so I haven't really looked much at the cost, and I'm sure it's really expensive. So that, I think, would certainly limit its use in clinical practice, but perhaps as time goes by and these novel agents become more of a mainstay in practice, we'll probably end up seeing it become more and more of a common therapeutic used in clinical practice. As far as the adverse events go, they did find a small increase in the prothrombin time, which usually would correlate, of course, to increased bleed risk and things of that nature. But in the trials themselves, they found that the risk of bleeding was actually pretty minimal, and they didn't see an increase in thrombolytic events. So that, but it's still something to consider. They also found, obviously, that abdominal pain that's common with the drug, and injection site reactions, which can also happen as well, being the sub-Q injections. And as well as that, we have some notes here on the administration of the drug, which would obviously be important for us as pharmacists to counsel on how to administer the medication properly. So it's a monoclonal antibody, so it's a biologic, so it has mostly a lot of stability concerns. So patients need to keep it in the middle of the refrigerator to keep it at the right temperature for storage. But then when they take it out of the fridge, because they're going to use it, they need to let it warm up to room temperature for 30 minutes. And do not warm it up with like a heat source, like a microwave or hot water, because that could damage the medication product and make it less effective, if at all. So also do not shake it because it's that MAB, it's that protein, so it can froth up and whatnot, and we don't want that to happen, so don't shake it. And they can administer it to the upper arm or to the thigh as you would a sub-Q injection. There's that loading dose for the first month, that's 400 mgs. And then there's the 200 milligram injections once monthly after that. We want them to also rotate their injection sites because they can have injection site reactions and things, so we want to minimize those. And do not inject the medication into like any scar tissue or moles or bruises, because that could make it more uncomfortable, and we don't want that either. So counseling patients on things like that is important as well. And like I mentioned as well, it's also light sensitive, so keep it in the original carton container it comes in, put it in the fridge, and do all those things to make sure you have an effective drug product that they can use. So here are just my references. I also have the references copied and at the bottom of each slide. If you wanted to take a closer look at those, they're also there for you as well. So I just want to say thank you. I really appreciate your attention to my presentation, and I have my email up here on the slide, but many of you already know how to find me. So if you have any questions, let me know, and I'd be happy to look into those for you. Thank you so much.